they're doing over there. Let me show you that other patient. Dr. Ali is going to be doing the other one. So here's the history on that one. The other patient is a 52-year-old male with chest pain, quite recent, it says. LV function in 57%. You see the lipids, there's some hypertension, and there's nothing before this. So apparently this is new onset of chest pain. Okay, here's an angiogram. And so the chest pain, okay, this says pre-PCI. So following that 8 hours of chest pain, apparently there was an intervention. And that's the right coronary, and this says post-PCI. So I'm assuming that an intervention was made. Can anyone see where the intervention was made? Okay, we don't have a clear understanding. Then this says baseline angio, and I must confess, I don't know whether that's the same time as the acute presentation. I think it must. In any case, you see probably the lesion of interest here is in the LAD. So I'm having to assume something. I'm assuming that an intervention, acute intervention, was done in the right coronary, and now the consideration is about this LAD right at a big septal, I think, there. Another view. I'm looking carefully at the left main because the name of this meeting is left main, so I have to be very, very much.
It's very septal bifurcation.
Yeah, it's the septal is quite compromised. That's an interesting discussion, I'm sure. So for complex bifurcation, if the bifurcation here is being defined as the LAD and the septal, I don't know if that's what they're after. So we'll have to ask them that. But it says these criteria, you've heard about these criteria several times in the course, the major and the minor criteria. They're giving this patient a very low syntax score. And saying that this is an LAD bifurcation lesion. So LAD and is that a diagonal or a septal we were looking at back there?
It's septal probably.
Let's go back and look at it.
It doesn't look like a very high-grade lesion, so maybe some functional testing will be helpful here of the LAD.
Yeah. I should try to go back.
Very focal and moderate LAD, so definitely I think
try to go back one more here. That's the best it's laid out.
Yeah, the RAO view is probably the best in visualizing the lesion.
Mm-hmm. Okay, then the question is Dr. Ziad Ali ready in that other room?
We are ready.
Dr. Ali.
Hi, Spencer, can you hear us?
Yeah, we can hear you. So we're in a little bit of a stuck situation in the other room, so we're flipping over to you, and we have a number of questions about the case. I didn't have a chance to get more information, so tell us a little bit about what happened. This patient came acutely and had something done to the right coronary, is that correct?
No, so patient came acutely with chest pain, and the only lesion that they identified was an ambiguous lesion in the LAD and a very tight septal perforator.
Well, that makes me feel better because we couldn't figure out what the intervention in the right was, but it was.
So there wasn't one. So you didn't. There's no BDS in there that disappeared in a week.
Okay.
So so the background here was we decided, I think as you just mentioned, that the most appropriate modality here is to use some type of physiological testing of the LAD in order to determine where there's a culprit lesion, where that ambiguous lesion was that you saw a little bit earlier on. So we're going to punish you and indulge you with a lot of technology. So what we decided to do was to use a new Angio-FFR system by RainMed called caFFR, coronary angiography FFR. We correlated that directly with an invasive pressure FFR. And we've also done an OCT to look at the plaque morphology of the LAD and found that the culprit lesion does in fact, well, we'll let you know in a second. So I'm just going to run through the angiogram with you, Spencer. So the key to a good Angio-FFR is a non-panning, zoomed out lesion assessment of the coronary artery. So in order to get a accurate three-dimensional reconstruction, you need corresponding but contralateral views at least 30 degrees apart. So this we started with an apicaudal. There's no lesion in the circumflex. You can see that there's that same ambiguous appearing lesion in the LAD and a very tight lesion in the septal. There's another view, and these, again, you'll notice that there's no panning at all, and the entire coronary tree is placed onto the angiogram. This is really fundamental to do a good job with your Angio-FFR.
So this patient had chest pain for 8 hours. Do you think that's a symptom related to the lesion in the ostium of the septal?
I don't know. And so that's exactly what we're trying to figure out, because I think what we have is an ambiguous lesion in the LAD and a rather peculiar looking septal arcade lesion, which typically doesn't cause angina, but we're not sure. And this is our last angiogram. So what we went on to do next, guys, is this is our FFR. So if you can move on to our FFR screen, we'll show you what we did. We performed our equalization here, which was 0.99. And then we did an FFR of the LAD, which ended up being 0.87. So what we're going to do is take a second now and show you the angio-based FFR system and how accurate it was and how we use it.
All right. Sure.
So can you go ahead to the camera? Can you point it towards the Angio-FFR, please? We need the camera and the Angio-FFR, please.
Was this an acute coronary syndrome, like any ECG changes or troponins or any cardiac?
No, isolated chest pain with risk factors of hypertension and hyperlipidemia. Can you show the screen, please? Oh, are they? Oh, you're good. You're looking at it. Okay, so let's go ahead. So we're going to run you through the process of doing an Angio-FFR with this system. So initially, when you start, what you're given is a selection of the angiograms that you've just performed. So as I mentioned, the quality of the angiogram is key. You need good contrast opacification of the coronary arteries and non-panning views of your culprit lesion at least 30 degrees apart from each other.
There's a great deal of overlap in that view. Is that a problem with it?
Well, it can and can't be, Spencer, because the angiogram, once you try to use the assessment, will tell you whether or not you're able to use it. So here what we've done is gone ahead and selected 2 angiograms, and what my colleague will do is show you how we perform the segmentation.
All right.
So for what we do here for the segmentation is we basically draw a center line down the coronary artery in the area of interest or the vessel of interest. And what the system will do is it will automatically define the center line and perform a contour of the angiogram. Once we've got this contour of the angiogram, we then need to do some fine detail segmentation of the arteries just to make sure that the angiogram is in fact accurate. We go ahead and do that for both vessels. And so once we've done that for both vessels, we then have a sort of QCA of the angiogram, which is used to reconstruct the coronary artery in 3D. The next thing that we need to do in order to determine the Angio-FFR is actually to measure the TIMI frame count. So can you show us how to do that? So the TIMI frame count comes out in the 2 views, and what we're going to do is identify the first frame where contrast is just before the first frame where contrast enters into the coronary artery. So show us that. Okay, select that, and then go ahead. And then distally, we show the first frame where we see contrast going into the distal coronary artery past the lesion. So go ahead and show that, guys. Okay, good. And you do that for both coronary angiograms, and then you press the FFR button. So let's see, go ahead and show us the calculation, just show us how long this takes. Can you press it? Just do it again. Can you do it, show them again? Okay. Right, but I wanted to show them how long it takes. Okay, so typically, this entire process takes less than 5 minutes. And so I think that's a major advantage, particularly in a situation like this where we had a sort of ambiguous or hazy lesion. So what you can see here is that our FFR in this situation is by angio is 0.89. So if we go back,
So what it's looking at is, as I'm understanding this, you're looking at the flow measured by the frame count, right? And the geometry measured by the edge definition where you segmented the area of the lesion.
exactly. So
Okay.
the other thing that we thought is because this patient has peculiar symptoms, we also, if you recall, if you look at the angiogram at the moment, there's also an intermediate lesion in the first or high diagonal. So this is the beauty of having Angio-FFR system is you can do as many of these as you want for all of the ambiguous lesions you have, because as we know, defined PCI showed us that 25% of the time we're actually missing the culprit lesion. So here you can see there's another lesion. So we actually went on to perform invasive FFR of this lesion as well. And the invasive FFR came up to be 0.93, and our angio-FFR of this lesion actually ended up coming up also negative at 0.87. So this system has a 320 patient study that's just published in Cardiovascular Research, which showed a diagnostic accuracy of about 90%. And in particular, I think the advantage of this system is that it showed in the gray zone between 0.75 to 0.85 that the diagnostic accuracy was also very high, almost 90%. So we found our LAD lesion is not the culprit. We found the ramus is not the culprit. And the only thing that sort of leaves is our septal branch.
All right, before you tell us what you're going to do about that septal branch, or not do about that septal branch, let's ask the panel. Who on the panel, this is 8 hours of pain that I assume you were convinced this sounded like ischemic pain, and he's got this septal lesion. Anybody want to take this on?
No, first of all, I want to know whether there's any troponin elevation or not. Is this a proven to ACS? And then secondly, before I commit to septal, being the cause of the lesion symptom here, at least we should do at least an OCT run of the LAD. For all you know, it may be a non-flow limiting lesion that's causing a rest pain here. So I would do an OCT before I do anything else.
Okay, we'll do that then. We've done that.
My only concern is going to be we don't really have ECG changes, no troponin leak. We really don't know if the pain was cardiac. This septal may not be the cause, and if you try to intervene on the septal, you may actually cause problem to that LAD plaque in there also. So I'm not sure how beneficial will there be to do anything to this septal.
So we're interested in, we're interested in the troponin. We're also interested in knowing what the LAD looks like with a more definition with the intravascular imaging with the OCT.
So we can show you that, Spencer. So we did an OCT of the LAD as the panel suggested. And Niels Holm, who's here with me, is going to show you an angiographic co-registration and show you what we found.
Okay, so thank you very much. And well, with Ziad in the captain seat here, no real need for OCT support, but we'll try anyway. We just start out with co-registration. Just a very few easy steps. OCT was recorded along the angiogram. And then just in a second here, we have the co-registration form so we can follow OCT into the angiogram corresponding. And we can see here, we have a bit of a jump here, but it's not in the region of interest. We will go here, have a look at the vessel. We can see from proximal, here we have the guiding catheter, we have the circ taking off at 7 o'clock, a bit of diffuse disease, first diagonal branch, and then we can see mostly fibrotic disease with a bit of lipid, small vessels in the vessel wall. And then we approach the segment here. This is the septal branch we have down here. And we can see actually just proximal to the septal branch, we do have a protruding calcified nodulus and also a maybe a small plaque rupture or a scratch in the surface here in a lipid plaque just here behind that. This calcified nodules also look a bit acute with a bit of irregular surface, indicating some thrombus. For those of you that are not so familiar with this, the calcified nodules is a mass of fibrin and calcific fragments, and it can be extremely hard. And this is the regular appearance of that, typical appearance. And when we go a bit further distal, we can see here we have the septal branch here at 3 o'clock, go a bit proximal again, and we can actually see we have this protrusion of another calcified nodule just here, very proximal to that. Again, must be expected to be very hard, and also could be something that is organized within a short time, but it could also be of older date. But at least this one looks a bit more acute and with a small plaque rupture just here to the right of it. And just corresponding to the FFR findings and the Angio-FFR findings, the minimal luminal area in this patient here is 3.0 square millimeters, so above the 2.5 threshold in an LAD. So the chance that FFR would be positive is very, very small, also related to the OCT findings.
So a very nice case for discussion. We've got a non-obstructive artery. We have maybe an acute syndrome. It'd be nice to know if there was enzymatic change. And we have a little roughed up artery. And what do we do about that?
So I think, you know, another thing that you can see here, if you go onto the angiographic of the 3D bifurcation mode on the OCT, it actually shows us the area of the calcific protruding nodule, which is over here. So, you know, this is one of the nice features of OCT. It actually highlights with these red dots all of the areas where there's a bifurcation. So there's no surprise, and then we know by angiographic co-registration that we're actually exactly where we thought we are. So as you said, Spencer, it's an interesting situation. So we have a patient who had 8 hours of chest pain. The only lesion is the septal, the FFR negative LAD, FFR negative ramus.
So is that troponin leak or not?
No, to be clear, there was no troponin leak.
Okay, so we didn't know that till now. So now we have, so with 8 hours of chest pain, we have no idea what it is. We have a septal lesion that is clearly potential for producing ischemia. We've got a node in the LAD without any evidence that it's causing trouble. Is finding a calcified nodule an indication for anything other than antithrombotic therapy?
8 hours chest pain without troponin leak is not an angina
non-cardiac.
or ischemic event. And so this may very well be a red herring here, just medical therapy.
That calcium nodule, when you try to intervene on the septal, could cause a problem to the LAD also, because you will be ballooning, inflating the balloon into the LAD from into the septum.
So Ziad, what's your plan here?
So I'll tell you what we did. Well, we decided to at least, we interrogated that septal by Angio-FFR, and the Angio-FFR of that septal was 0.57. So it's clearly very ischemic for whatever it's worth. So what we decided to do, because the patient's on the table and was having chest pain, that we decided we would at least take a gentle approach to the septal. Now, as you can imagine, Spencer, it wasn't that easy to wire this artery. We actually had to use 3 wires. This is a Xi'an blue that would not cross. We then tried a pilot 50 that did not cross. Finally, we got a Fielder XT into the vessel. And so what we did actually is we did a very gentle balloon dilation with a 1.0 balloon. And then we upsized after that 1.0 balloon to a 2.0 balloon. So there's not a lot of improvement there. This is a 2.0 balloon staying away from the LAD. And that's basically where we are. We decided, I mean, we're obviously not going to stent this. The target lesion failure of a calcific protruding nodule is very high. We had a tough time getting into this. If we have a tough time dilating it, certainly we're not going to be rotablating into the septal. I think what we've done is opened up enough space. We've proved that by angiography and by invasive FFR that the main vessels, the diagonal, which was the question as well as the LAD isn't ischemic.
So let me ask you this endpoint. The patient was on the table having pain, and you've opened this up. Was there any change in the symptomatology?
None at all. We specifically blew up the balloon, asked the patient whether he had any symptoms, and he denied it.
And what about a post-PCI FFR?
We're going to do that.
So I've seen, in your defense, there's not enormous enthusiasm for treating this septal on the panel. As I'm looking at them, they're all looking rather glum. But in your defense, I can remember a case or two that a person did develop a chest pain that sounded quite legitimate, and the only thing I did was tweak up the septal perforator, and the pain got better. All I'm saying is I think a septal perforator can cause pain. 8 hours of pain without a change once you restore the thing probably is strong evidence against this being the etiology. But
I think we tried to take a thoughtful approach to this, Spencer, by using physiology and proving that the main vessels were non-ischemic. But nonetheless, the patient did come to the hospital with chest pain, and the patient's on the table, and there's a 90% lesion. We took a relatively, I would say more than relatively, took a very conservative approach using small balloons, less than the size of the artery, with minimal risk to the patient. So I believe that we've done what we can do in terms of risk versus benefit, and it is possible that this may help the patient's symptoms.
well, we've learned a lot from you about this Angio-FFR, and I think this has been very interesting to have a look at that. I think maybe we could check the other room and see what if a solution has been found to this obstruction of with stent or in the LAD. Yeah, no, you want to ask them something?
Yeah, I have one question. Do you want to do an OCT in LAD now to see if you have moved this calcified nodule that was protruding into the LAD by the ballooning? Because the prognosis of the patient is mainly the LAD status when you discharge him.
So, sure, we can do that. Our plan was to do an Angio-FFR. I mean, the likelihood of us moving calcific protruding nodule was exceedingly low. And we made sort of sure to not focus our balloon in the LAD. But since we paid for the catheter, yeah, absolutely, we'll do it. And if you guys have time to come back, we'll show you the post-PCI FFR as well as the post-PCI OCT.
All right, we've had a whole morning of antiplatelet therapy, so I'm sure you will apply some to this patient
I think that's
very judiciously.
Yeah, I have
in
a
fact,
simple question.
that's one of the areas where I think this can be a long-term benefit. I think this prescription of DAP for this patient for the long term, given the calcific protruding nodule, is probably the best therapy that he can get.
Yeah, what's your strategy for DAPT for this patient? You just balloon a very small branch of this septal, and the patient may be suspected ACS.
I would say that the patient should be on DAP unless there's a bleeding problem. For two reasons, not necessarily because of the chest pain or the ACS or even the ballooning per se, but the fact that there's a calcific protruding nodule that's in the lumen in the LAD, that's clearly a nidus for thrombus. So our plan will be to keep the patient on DAP until indefinitely, unless there's another reason not to.
Okay, could we take a look at the other room and see about Robert and Gary? Okay, Robert, we can see you now.
Yeah. So first of all,